Hello, good afternoon to everyone. My name is Enrique Terol. I work for the European Commission in DG SANTE in Unit P3. I am working in the team of European Reference Networks, and let me welcome you to this webinar that is part of a series of webinars we have been organizing since March, when the crisis, the pandemic started, and we thought that it was very important to give our support to you, to the clinicians, to the experts that are dealing in your daily life, in your work with this infection. And we have been looking to different topics and elements and speakers that could give you some hints and also to provide you update on the state of play, the state of art of different aspects related with the COVID infection and other diseases. In this case, we have the honor to have a co-organized meeting with the European Society of Intensive Care Medicine. As you know perfectly, intensive care medicine is the key element that has been involved in the treatment, in the management of the severe cases of the disease. And that's what we are going to listen today. Just let me give you a couple of tips on the logistics. You will be muted during the webinar in order to avoid any noise, because it's very difficult to control otherwise the quality of the webinar. And we will ask you please to intervene in two ways. Either, if you have a question to the speakers, please write you a question in the question and answer tab to host and presenters, and after the speeches we will come to you and we will raise the questions and we will have an interaction with all the participants. If you have just a general comment that you would like to share with all the audience, please include that in the chat functionality, and that will be seen by all participants. This workshop will be recorded. If you do not wish that your name appears or you are named, then you cannot ask a question because you will be addressed when answering to your question, or not to intervene. All the presentation and the recording on the meeting will be made available after the meeting in our website. You will receive the link to this, and also you will see a short survey that will pop up once the meeting is closed. Please, I will ask you to fill it. It takes just 3 minutes, and it's very important for us and for the speakers to know what's your input and your feedback on the speech. So, just to make that short, today we have 3 important persons with us. First of all, it's not the name here. We will have the director in DG SANTE that is dealing with the healthcare and with all the aspects related with medicaments, medical devices, European Reference Networks, and healthcare systems, which is Dr. Andre Ries. And after that, we will have the presentation done by the President-elect of the European Society of Intensive Care Medicine, Professor Maurizio Secconi, who is also the head of the Department of Anesthesia and Intensive Care Units of the Humanitas Research Hospital in Lombardy, Italy. After him, we'll have Professor Joseph Kesioglu, who is the current president of the European Society of Intensive Care Medicine. It's a worldwide known expert on ethics and intensive care, and it's the head of Intensive Care Center of the University of Medical Center of Utrecht in Netherlands. So, as you know, this webinar is under the frame of the support we are trying to give to the clinician dealing with COVID patients. You will find in our web pages all the links and all the ways to find more information and the support to the system. So now I will pass the floor to my boss and dear friend, Dr. Andrew Rees. Please, Andre, it's your turn.
Thank you, Enrique, in this webinar, and it's a very pleasure to get more information, knowledge from you, especially from the weeks, difficult weeks of fighting on the front of COVID-19. We are sharing this information also to be better prepared, to think about the future, think about the potential training program, but also needs, for ICU across EU as a key. Training is a solution, as you told me last week, but also a good preparedness and the vision of the future is important factor. So I again welcome you on behalf of DG SANTE and the European Commission, and we go ahead with our program today. Over to you, Maurizio.
Thank you, Andrea, and thank you, everyone, and really thank you to the European Commission and to DG SANTE to give the European Society of Intensive Care Medicine the opportunity really to be here and to share our expertise or our experience at least. So I will start. I'm going to focus on the surge ICU response. Just to give some background, I am the head of the Department of Anesthesia and Intensive Care at Humanitas Research Hospital in Milan. I moved here 2 years ago. Before that, I worked in the NHS in the United Kingdom for 14 years. I was a director of critical care at St. George's Hospital there, which is also being on the front line for the outbreak in London. And I've been in contact with several colleagues, also some friends. Joseph, our president, we talked a lot during the first days of what was happening in Milan in end of February and March. So our story goes like this. On the February 20, 2020, a patient on his 30s admitted to the intensive care unit in Codogno Hospital, Lodi, Lombardy, in Italy, tested positive for a new coronavirus. That's a crucial moment in our story in Lombardy. Indeed, I remember only a few days before I was in America with Joseph. We were attending the Society of Critical Care Medicine, which is basically our counterpart in America and the US. And this was one of the slides that I prepared for a talk on data science. The Society has invested a lot on artificial intelligence and data science. We have a new section now. And before COVID, that was one of our strongest focus on how we could make data more available for the needs of monitoring, benchmarking to be used on patients. So funny enough, then COVID-19 came out, and you may have all seen this John Hopkins world map. Now look at this. This is only 4 days before that specific case was discovered in Italy. And Codogno was really a place that no one knew before that, not even in Italy. It was a very small town. You can see here that Italy was not even on the list of cases. However, what we realize now that probably there were a lot of undetected cases in the community, and I suspect this is a common theme for many of the stories there. Indeed, up to that moment, we were thinking that we were able to trace and to contact trace pretty much everyone that was coming from China or that was positive for coronavirus. Contacts were screened, they were put in quarantine, so we believe we didn't have a problem. That 20th of February was waking up with a nightmare for us. That patient was a patient on his 30s. He was an athlete, no risk factors. The intensivist in that small hospital had a very important idea, which was this patient is not responding to the initial treatment. I'm treating this patient for atypical pneumonia. This patient does not have any risk factors for the coronavirus, so there was no reason to test for it. However, there was something wrong, so she decided to force the local protocol, and after some negotiation, she was able to get a PCR swab, nasopharyngeal swab. A few hours later, this becomes positive. This for us is the beginning of a nightmare because it means that we have probably a secondary transmission now in the community. That was not detected, the filter was somehow missed, and this is something that we've noticed then on other epicenters, on other clusters, happening in Europe and in America. Just to give you the magnitude of what happened after that in Italy, this is the current data from our Italian Health Institute. This is the number of cases that we have now, 230,000 cases. About 75% of these cases are in Lombardy, which is where I live. Lombardy takes into account about 1/5 of the overall Italian population. As you see, we had about a 13.7% case fatality rate. I will come to this with a little bit more detail now. And the healthcare workers got infected in about 10-11% of the cases. So a very important virus. This is something that you have seen also in many other countries now. But for us, clearly, having been the first cluster outside of China, the violence of the secondary transmission was something that really caught us by surprise, and we had to mount an immediate response to try to cope with the first days of what was happening. This is the case fatality rate for Italy. If you look at the case fatality rate for different countries, you do learn actually quite a bit. Indeed, if you look at where the majority of deaths occur, they occur in the later decades of life. So if you separate by decades of age, you will notice that after the age of 60, really the mortality for positive cases becomes very high. And this is probably a very important message for something that does not have a vaccine at the moment, for something that does not have a specific cure. What we've learned in the very first few days was that containment in the community is probably one of the most important maneuvers that you can do. What we do in the intensive care is try to buy time for those patients where we believe they could benefit from intensive care. However, it's not enough if we don't contain the virus transmissions, especially for the decades of life that are after the age of 50. If you notice this number, you may see that below the age of 50, we had about 400 deaths in Italy. And after the age of 50, there is a concentration of about 30,000 deaths. During the first few days of the cluster, what we did, and was probably one of the many things that we may do differently, I suspect going back on time, there was one thing which I think was crucial and probably helped us not to collapse. The local government called an ICU network. This ICU network was in place before COVID-19. And it was in place in order to provide extracorporeal life support for either respiratory failure or for heart failure. So this was a network of 15 hospitals that was in place even before this. And we were able to use this initial network basically to mount the contingency response. I remember meeting with the network on the very first 48 hours after the first case of secondary transmission. We already had now 5 cases, another 10 cases that were coming to the intensive care units because the risk criteria suddenly changed and everyone got tested if it was coming from one of those areas and with respiratory failure. And what we noticed was that the percentage of cases that was requiring respiratory support, advanced respiratory support, either in the form of invasive mechanical ventilation or high flow nasal cannulas, higher degrees of oxygen requirement, was very high. At the beginning, we had something like 10-16% of the positive cases. We noticed this in the very first 3, 4, 5 days. The trend was significant. I remember during those days calling Joseph Keseshoglu. The next speaker is a friend, he's the president. And I was telling him, Joseph, this is something very serious. This is not a flu. What we are seeing here is somehow even worse than what we were expecting from China. And from initial Chinese data, we were seeing critical illness in the Wuhan cluster of about 5%. What we were saying here really was a very high number of patients requiring intensive care. You have to remember also the background pretty much for everywhere in Europe. We are now in February, March. February, March is still winter and is still peak season from pneumonias, flus. We have a lot of surgery going on. Most of the intensive care units, they run at 95% capacity. In Lombardy, we had 720 ICU beds open for level 3 support. We have more beds for level 2 support, but the beds for level 3 support were 720 at the beginning of the crisis. So this, probably, we had only something like 50 beds that were available on those first few days. What we did was closing immediately the elective surgery in order to create capacity because we noticed the large number of patients that was coming. We worked with the local authorities to try to contain the initial areas, and we did a huge effort to try to increase surge ICU capacity. When I spoke with Joseph about this, we thought, if we got surprised in Lombardy, which is probably one of the most developed areas in Italy, and one of the richest healthcare systems in Italy and probably in Europe, is also compared with a significant number of resources, we need to send a message out to the world. Probably a lot of people have underestimated this. We need to try to give a few days, maybe weeks of preparation for others. So we sent this letter, and I'm very thankful that Joseph gave us this voice. This letter circulated to thousands and thousands of clinicians. It went even to news, and it triggered an initial preparation in the intensive care community. Our message was very simple. It was a get ready. Increase your surge ICU and hospital capacity. We had it very clear that it would be wrong just to focus on ICUs. Containment of the virus transmission had to be the priority in the community and in the hospital to avoid making the mistake or making the errors to become a cluster in the hospitals. We say do not work in silos. It takes a whole hospital, a whole healthcare system to mount a response like this. We found that it was very important to train, to simulate, learn and share, and we did that as much as we could from Lombardy, from everywhere in Europe. With the European Society of Intensive Care Medicine, we started to do a series of webinars immediately. We contacted Chinese doctors. We started to share as much as we could with everyone. Of course, it's important to protect your patients. It means protect other patients from becoming infected, but also protect your healthcare workers. Just to give you an idea, 20th of February, we discovered the first case. 2 weeks later, we are on the 5th of March. We realized with the work of the Foundation Bruno Kessler in Trento and Professor Merler that we were on an ascending phase about to kick off in terms of an exponential increase in ICU admissions. At this stage, we already had a lot of ICU admissions in the region. We were about between 300 and 400. If we would have not put measurements in place to contain the virus, the potential could have been up to 14,000 ICU admissions by the 20th of March. No healthcare system can sustain this. This is the time where there was an extended lockdown of the Lombardy region and then of the whole country. If it was a linear growth, we would have had 870 ICU admissions by the 20th of March. We didn't achieve a linear growth because the contagion has already gone through, but we were able to cope. And what happened after that? We saw the maximum number of patients coming to our intensive care unit in one single day in 24 hours was roughly on the 17th of March, which basically is 151 ICU admissions. Just to give you the magnitude of it, this is 20% of the pre-ICU capacity in a single day. These patients spend between 10 to 14 days in the intensive care. So after that, we started to slow down the ICU admissions, but the occupancy still went up, and we peaked about on the 2nd of April. After that, we started to breathe a bit more, and as you see now, we have a significant number of beds ready in case of a second wave, and we started to redo now some other activities like elective surgery and other healthcare procedures that were stopped to create space for the pandemic. This is the first case series that we published on JAMA on the ICU patients that were coming to our region. Again, it's important to remember that in the Italian healthcare systems, when you talk about intensive care, the majority of the time you refer to the sickest patients, is level 3s. There are some other level 2 areas. And indeed, if you look at the total number of beds that we had to increase from a baseline of about 720 per 10 million people, we increased about 1,500 for COVID-19 at the peak of the pandemic. We had another 300 for all the other emergencies, which is about 1,800. And plus, on top of that, we had another 2,000 for non-invasive ventilation, like flow nasal cannulas that we set up in other wards. So we had to increase in 6 weeks our intensive care capacity of about 4 or 5 times. It was a massive effort also because, as you see from here, the PaO2, FiO2 of these patients was very low. PEEP requirements were high, FiO2 requirements were high. These were properly sick patients that we had to manage. And the difficulty was, how do you create this extra capacity and how do you bring all these competencies at the bedside? I'm showing you this also because it's the median age of our population. In order to care for everyone that could benefit from intensive care, regardless of their age, we really had to put a huge effort on the system. Indeed, 62 years of age is exactly the same age that it is in the overall Italian population, even for patients that were not requiring ICU admissions. In order to surge, pretty much everyone did use similar approaches. What I was saying before is increase the capacity, but also separate patient flows. Separating patient flows is something that you can do from ambulances admission, from self-presented patients to the emergency department. If you came to our hospitals, the majority of hospitals in Europe, everyone that had to deal with COVID, we separated patient flows in order to basically avoid cross-contaminations with other patients that were not infected, and also to protect more in cohorted areas people that were working with these patients from people that were not working with suspected cases or with other cases. We did put a lot of effort also in simulation and in training. This is the example from my hospital. Within the first 48 hours, we increased the first 12 extra beds. In order to do that, no one was prepared to work in these conditions. That's another learning. We should always be ready for situations like this. We did a lot of simulation with an in-situ simulation team. We trained 80 clinicians on donning and doffing. This is far more than what anyone has done in the unit before. We had a group of people that were already able to do it, but we wanted everyone to be able to do it by the time the first patients were coming. And we trained everyone to do this. We've dressed with proper gear and do procedures like intubations, proning. We also used random drills during the day after, even when we didn't have a lot of patients in the unit. Patients came up very quickly though, and it's very important to understand how, with an exponential phase of increasing capacity, how can you bring those competencies to the bedside? I would say that there has been almost too much effort in talking about equipment, and on this, of course, equipment is important, of course, bed space is important, but if I have a learning point from this, to me, the most important thing is how do we bring the competencies of intensive care doctors, of intensive care nurses, to people that never worked in this environment. In order to do this, it was a fantastic effort of teamwork. We had nurses that never worked in intensive care before. We had doctors that never worked in intensive care before. Everyone tried to do their best. However, it was not easy to bring all these competencies there at the bedside. And I think that's something to learn from the future. We cannot have the same response in case of a next pandemic. I think we need to be ready to have even more competencies so that we don't have to dilute the supervision to all this group of people. We've learned also a lot of other things during the virus. This was a new virus for everyone. There has been a lot of talks about immunomodulation. I will come back to show you a review that we recently published on intensive care medicine. One interesting topic for sure has been thrombosis. We've noticed in this group of patients that there is a high rate of thrombosis and pulmonary embolism. So everyone, I would say now, has a low threshold for searching, for screening for it. There is definitely a lot of thinking around lower thresholds for anticoagulation. I wouldn't advocate anticoagulating everyone, but certainly we should have a low threshold to think about it and to maybe to increase the dose on some patients if we think that there are higher risk of developing DVTs and thrombosis. Together with the Italian Science Academy and Guido Forni and Alberto Mantovani, we recently published this paper on intensive care medicine. It is 10 things that we learn about the coronavirus. And as you see, we still have a lot to learn. There is a lot of potential pathways how the virus can enter the human body and cause harm. And the modulation of these responses is going to be crucial to try to find solutions. And I suspect, looking at what happened and reports, there has been maybe a little bit of anxiety on clinicians to try to find quick solutions. The reality is that this is a new disease, and I don't think we can say that we have a specific therapy. There is some early data on remdesivir, but the data is not huge in terms of effect. It's an important first step. We need to do more steps into that direction. Certainly, we need to do more high-quality research. There is a lot of evidence that we don't have evidence on many of the drugs that we're using, maybe potentially even some harms. We talked a lot about immunomodulation, thrombosis, anticoagulation, and plasma and steroids are just some of the key topics there. I would say there is still a lot of uncertainty, and hopefully we should be better equipped with new studies and new studies that will be published soon. Another important thing in terms of preparedness is this. We had some studies that were coming out, like REMAP-CAP or Solidarity, that were prepared to be worked during a pandemic. And I think we need to work more on platforms like this for the future. We need to have an infrastructure of data science, an infrastructure for looking at how we can implement research without the usual lags and delays that can happen in situations like this. Otherwise, the risk is that we will always try drugs without evidence, and we will miss the opportunity to do proper trial data. So the principle of primum non nocere, which means first do not harm, needs to be there. We need to try to use drugs when we have evidence for some efficacy and also evidence that they are not harming our patients, first of all. I'm going to show you just a little bit of data also on what probably is the only evidence that we have so far, is that supportive therapy for those patients that would benefit from intensive care is probably very important. We've learned a lot from the past in terms of protective lung strategies and how to use PEEP on these patients. This patient, we've noticed very early that a pattern which is quite common. They tend to come with significant hypoxia. However, normocapnia is very common. They seem to have a good compliance, the majority of them at the beginning, even if there is variability in the presentation and every patient is different. But as you see here, this is data that were now submitted from my group. You can see that there is a significant response from a low PEEP from 5 to 10. However, only a few patients will respond to a higher level of PEEP. So the majority of patients will be able to be managed from a 5 to 10 PEEP. A lot of these patients receive prone positioning. Prone positioning is a technique, again, that we use in terms of protective lung strategies. It allows a better ventilation perfusion match during in the pulmonary circulation. And as you see, a lot of patients had an improvement in the oxygenation PL2 FiO2, and they went back to lower PL2 FiO2 when they were put supine. So this was definitely something that we used and we thought was helping us to ventilate more gently our patients. We tried to use also nitric oxide. There was a little bit of hope at the beginning. Our experience is that we didn't see a lot of improvement to this. However, it's small numbers and maybe there will be further research on the line. Again, after 3 months, we don't have a lot of physiological data that has come out on this patient, and we're waiting for that and also for some trial data. I'm going to show you also something about non-invasive ventilation. This is a helmet. Helmets are used very commonly in Italy. There is a long-standing tradition of it. However, the principle of providing in a non-invasive way some positive pressure to the lungs is similar to CPAP masks. And what we do with this was basically try to give non-invasive ventilation better. We prefer to refer this to CPAP rather than a non-invasive ventilation in Italy, because when we talk about non-invasive ventilation, even if CPAP is part of it, many people would consider that you can even give some pressure support on top of the baseline PEEP. Actually, for us, when we were giving pressure support on top of baseline PEEP, there was kind of an indication to intubate or to decide that the patient was getting tired. However, we had patients that were dealing okay with positive pressure only. Just to show you some data, again, this is something that we had just for my hospital. We managed about 260 patients in total between level 3 intensive care and level 2 intensive care. For the level 2 intensive care, we had a group of patients that was managed just on CPAP in the ward, never got intubated. If you do a good selection of these patients, these were 30 patients, 96% of these patients were discharged alive from the hospital, didn't go to intensive care. Many people would ask, though, what about those patients that go to intensive care afterwards? Did you tire these patients? Did they get very tired? Again, if you have a protocol in place, which is what we did, and it was exactly trying to avoid getting these patients tired. So we were doing early intubations if we were seeing that patients were not responding to CPAP. However, some patients were tried on CPAP, and then if they were going to intensive care, again, 76% of these patients were discharged alive from the hospital. We still have about 23.5% of these patients that are still in hospital, so the mortality clearly could go up. However, I would say that I didn't change my practice compared to pre-COVID, I tried to apply basic principles of respiratory support to a larger group of patients. It has been a huge team effort. This is a picture of my team into the first of the extra intensive care unit that we created, cohorted ICUs, because we didn't have a number of negative pressure individual rooms to search. We had to do this in large spaces, so we created this way of working with personal protective equipment and shifts where everyone was working always in the same space. It has been tiring, however, it has also been a very unifying moment. We had very important moments. It's not been easy. Joseph will talk later about how difficult it was not to have families at the bedside. However, I also think that it was something where we learned a lot, and we work very well together with doctors and nurses at the bedside. To conclude, what about phase 2? What about a next wave of COVID? We don't know if there will be a second wave of COVID. We don't know if there will be another pandemic, but it is likely that we will be faced with similar problems like this in the future. We don't know when, but it can happen. I don't think our societies, I don't think our countries in Europe, probably no country in the world can be surprised twice. The lesson for me is that we need to increase ICU competencies. It's not just about ventilators. It's not just about bed spaces. It's about how do we increase competencies for people to care for these patients in the best possible way. Maybe we need to consider moving competencies. What about an healthcare army? Everyone worked a lot in individual countries by increasing capacity and creating space. Maybe we worked in silos there. The pandemic didn't move at the same speed everywhere. Maybe we would miss an opportunity to bring competencies where they were most needed and then to move them to another place. Certainly, work on containment in community and hospital. We cannot believe that we'll be winning just increasing ICU competencies and ICU beds. We need to work as citizens. We need to work as with public health authorities to contain the transmission of the virus in the community and, of course, also in the hospitals. And it's very important to work in networks, clinical networks, scientific networks, share as much as you can, and always keep the principle of protecting your patients and your healthcare workers. We need to protect our patients that are not infected. We need to protect our healthcare workers. And I believe also that we need to be more prepared with high-quality trial data and more data science, more sharing data at European level to have a larger data science concept that could really help us to manage this better. I'm concluding. This is my last slide. Unite COVID. We want to be united, and Unite COVID is our current observational studies on practices of intensive care in COVID-19 patients. Is being led by the research group of the European Society of Intensive Care Medicine with Jan de Waal and our society, and we hope that we will get a lot of insights from this research in the future. Thank you.
Thank you very much, Maurizio. That was an incredible talk, so not only from the professional perspective, also from the personal, and thank you for sharing your experience during this 2-3 months that were probably something that will change the complete scenario of the healthcare forever. So now let me pass the floor to Professor Joseph Kesiokoglu. And let's see, Joseph, now you are you have the role as speaker. You can share your screen. Perfect.
Okay, thank you very much. And again, thank you very much for inviting us to this webinar. We are very much honored of it. And in the coming minutes, I will start with the patient and family and go on with the healthcare professionals. But before I do that, just to show you where I come from, this is the ICU of mine, built on the roof of the hospital in Utrecht. And you will see some pictures of it. And I will just give a little bit of a historical knowledge just to explain you how did we come actually all the way from 1852 to March 2020, when things have changed. The idea of ICU comes actually from the Crimean War. Florence Nightingale has actually kept the severely wounded patients together, so in one separate place for special nursing care. And this concept has been used many years later during the polio epidemics in Copenhagen, and this has led also to the first intensive care units. And you see some example there, the first intensive care units where the patients were kept together in special wards in order to observe them and wait them to get better. And at those times, I have also been starting in my profession. It was a bit arrogant from us just to think that everybody should be thankful if the patient lived and discharged from the ICU. And okay, there should be some trauma, but it was acceptable. Luckily, the last 2 decades, we started to have more and more insight on mental stress of the patient and family next to the systemic problems that they were having. At the same time, we also realized that well-being of the personnel and the safety procedures are also extremely important. So what we then developed as concepts was by, for example, private rooms, so that patients can have more privacy, more quiet. The family communication with the family members is better. The family support to the patient is better, and the medication errors are less. We have also said in the new built ICUs we should have natural light, so that the patient has day and night rhythm, and this would reduce also the agitation of the patient and other symptoms. We have also said the patient needs to feel at home. 30 years ago, the hospitals were just 40 years ago, white wall, white beds, white everything. Now we try to give some humanity to the ICU, so that patients and the family members are not in a very strange atmosphere. What we also did was we also tried to cover the needs of the family. We just gave them a room to have food and coffee, so that they could just between the visit of the patients just at least relax a little bit as much as they can. Another interesting development was the 24 hours visiting policy. We also said the family should be able to visit anytime they want, and this has been applied with great success and with great pleasure of the family and the patient. And we also have the habit of giving regular information to family members, at least 3 times a week if the patient is staying very long, and that it happens face to face with the family in a calm room without being interrupted. Now, what happened? Then we were hit by COVID-19. So we had to go out of our ICUs, and we had to go to other locations as well, because the beds that we had in our ICUs were not enough. Then you see that we were in a location which was not originally built to be an intensive care unit, without any privacy, a lot of noise, the patients laying next to each other very close, and the personnel is walking around. They have to communicate with each other. And we had also frightened patients because the personnel had to protect themselves, so they were having protective clothes, masks. Patient couldn't see the face of the patient, and the physical contact was gone completely. What I mean by that is we had a film made, and one of the persons in it was one of our nurses. She said, I knew that the patient was having a lot of anxiety and fear. Normally I would sit down next to him and hold his hand, but I had my gloves, plastic gloves. It didn't give me the same feeling. What we also were confronted that the family could not come to visit in some of our ICUs, and in other ICU where isolation was possible, we were allowed to bring one family member per day for a short time, but with a lot of other ICUs, they could not visit at all. The environment, again, as I said, without daylight and any other comfort was not suitable. And the other thing is that the patient could not see with whom he or she was being in contact. You could see only the eyes of it behind eyes of the personnel behind the protective pair of glasses. And we also saw that the rate of delirium of those patients were quite high. So what we got was from 24/7 to almost no visiting. Even if it was possible in our isolation rooms to come for a short visit, a lot of family members were having fear and they were not visiting us. There was also no face-to-face meeting left with the nurses and the physicians. They were called once a day and information was given to them. And in cultures where the family wants to be with their loved ones, if the person is dying, we were allowing them to come in a short group, and we were clothing them, protecting them so that they could go in. But after 3 weeks of ICU, the family could not even recognize the dying patient because the patients change in ICU. And if you are able to come every day, you will observe that process. But if you come only 3 weeks after, they had quite a difficulty with that. Now I will give you a couple of examples from studies already performed 10 years ago. You see, these are patients with acute respiratory distress syndrome. This is a syndrome which we often see in ICUs after it can be a big operation, it can be a big trauma, it can be a pneumonia. And with COVID, we also had a similar syndrome, although it had quite a lot of differences. But the effect on the patients, I think they are quite comparable. You see that with these ARDS patients, younger patients had a greater rate of recovery than the older ones, like in COVID, very similar, but neither group returned to normal. So there was always something remaining, something like physical or psychological problems or some memory problems were developed or persisted. We also see that not only the patients were affected, but also the family members, and actually the burden was the same with the family members as well compared to the ARDS survivors. And in this report, actually the relatives experienced more PTSD, post-trauma stress disorders, and depression than the ICU survivors themselves. So I will just go to the healthcare professionals now for a couple of minutes. What was COVID-19 for us? It was an unprecedented situation. Now, why I say this unprecedented situation? Because we have major incidents. There can be a terroristic attack somewhere, and then you know that there are 200 people wounded. The people come to the ICUs, but then that's it. Then you have weeks to treat them, and you have everything under control after the first, let's say, 12 hours, or even we can call it 24 hours. But with COVID-19, they came, and they went on coming, day in, day out, and there was a surge that you could not know when the end is coming. That's why I called it an unprecedented situation. we had to make impossible decisions. We were working under extreme pressures. I will come into the detail in a moment. We were confronted with balancing our physical and mental health care needs with those of the patients, because we were also worrying about our families and friends. We had to find a balance between the duty that we had to our patients with those to family and friends, we had to provide care for all severely ill patients with inadequate sources, because when the numbers were so high, suddenly there was shortage of many things that we normally needed. The Litz and colleagues have described more than 10 years ago the moral injury. The moral injury is described, and it's not only for medical health professionals, medical or nursing, but moral injury is a situation that causes psychological distress due to some actions or not being able to do the actions, like not being able to give the care that we give to in normal time to severely ill patients. And it violates personal, moral, or ethical code of the people, and it is not a mental illness, unlike post-traumatic stress disorder. But it can contribute to the development of mental health and difficulties if it's not interfered as soon as possible. And those who develop moral injuries experience negative thoughts about themselves or about others, and they have intense feeling of shame, guilt, or disgust. So it's a very important thing within the health professionals, and we have seen this during the first days when the patients were coming more and more, that there was this shame of I cannot give them the care that I should be giving. And this is also explained very well with the short article of Greenberg and colleagues. Actually, these are not the words that we always use, but he has put it in a very nice way. In a normal situation, when a patient dies, we could say to the family members, we did everything that we could. But now we are not in state of saying that, because we cannot do everything what we could during this COVID crisis situation. What we can only say is we did our best with the staff and resources available, but it wasn't enough. With the medical and nurses staff and resources available, but it wasn't enough. So there are certain things that we can take lessons from. What we need to do is to prepare the staff for the job and the associated challenges, and give a full and frank assessment of what they will face. So our advantage in the Netherlands was the fact that we were not the first country in Europe. So I had quite a lot of information from my friend Maurizio, and we already started 2 weeks ago, 2 weeks before the first patient came. And we had just told the people what was accepting us. The problem is, you should never give false reassurance. Many of you will remember that our governments or the authorities, health authorities, they just said this cannot happen in our countries. It did happen. So the shock is much greater if you give false reassurance and suddenly they are hit by the reality. And we should not start, come on, we can do it sort of things. Just plainly explain them what is expecting us. And the support is very important once everything starts, because then you need a culture so that people can safely discuss their emotional and social challenges of caring for the patients. Leadership is very important. Trained peer supporter is very important. Psychologists are necessary. And we need to explain to our people, to help them, that these are not regular times and we sacrifice from the norms that we apply. The leadership has the job to do this. The leadership has to take the responsibility that if there is something happening to those patients, which you think that it should not happen to other patients in normal times, the leadership is responsible for this, and you are not to be blaming yourself. Then, of course, the crisis is over, and what usually the hospital expects, because there are some disciplines who did not have too much work to do because most of the operations were cancelled, they would like to start immediately with huge amount of operations and admissions and etc. We should say there, just be careful, because we need debriefing. We need to give a rest to our personnel. We need to learn from the extraordinary difficult experiences so that we prepare ourselves to the next crisis. We need to monitor our staff actively in order to monitor the ones who are not feeling well and who cannot express it, who cannot say it, who are ashamed to say it, so that they can be assisted, because we need our medical and nursing staff. We cannot afford to lose them. There are, Roycroft and colleagues have advised actually 3 key strategies. The first one is complex decisions should be taken in a group rather than at individual basis. Intensive care is a place where most ill patients come, and we unfortunately have dying patients. In this case, with COVID, they were maybe 10 times more because of the numbers that we got. Maybe the percentage was quite okay, but the numbers were very big as patients. I mean, just as an example, I had a 24-bed ICU. With COVID, we went up to 80-bed ICU. So there will be much more patients where you have to take very complex decisions. Loneliness there is a big problem, and to share it with other clinicians will help for the prevention. The second thing is the provision of time and space for clinicians to decompress. People have to rest. That's why some hospitals increased the working hours to 12 hours. We said stick it to 8 hours. But it's easy to say than to do it everywhere, because you need the personnel and you don't have them in enough numbers. But it's one of the important issues that they can rest and talk about it. It helps a lot. Then I am coming to the third point, and it is advised staff working consistently in the same team. But this is again a very important issue. Again, it's easy to say than to apply, because we know that consistent teams allow development of the mutual support, and emotional and moral distress is reduced. And of course, if there is somebody not feeling well, the medical and the nursing staff are much better at picking up the distress in their colleagues than in themselves. So it will be easier recognized if you have the same group working together. However, I just put this picture here as an example. At the deepest point, we had help from the military, and they were sending their young nurses and physicians to help us as nurses. And you see the cultural difference. I mean, it was going perfectly, but you can't keep a team constant here. It needs to change, because you need the people, and it's not always possible to make a team. And don't worry, this is not inside the ICU. That's why they are practicing. That's why the soldier is in his normal uniforms. I would like to summarize that the pandemic has put the patient, family, and healthcare professionals under physical and emotional burden. At this moment, we don't know how deep this burden is. It will be probably published in the coming months, but we expect that to be considerable. But having said that, I'm also quite proud of the fact that all our medical, nursing, and all the other logistics and everything in every European country that I'm in contact with a lot of colleagues, they have done a great job. We maybe could not do everything what we wanted with the patients, but it was done still. The job done was great. I would like to stop here, and maybe we can go back taking some questions.
Thank you very much, Joseph. I will thank you for the really interesting and deep presentation on this issue that it's probably touching all of us, no, especially your colleagues, the healthcare workers, no, how to deal with this extraordinary situation from the ethical point of view, no, and to deal with.
So the question is, how should we deal with it? Did I understand correctly?
No, what I am commenting is that it's what you have presented, no, on how the.
I think I have lost the sound.
Joseph, can you hear me? Can you hear me? Seems that Joseph has.
Yes, I can hear you, Enrique. I can hear Joseph, but it seems that Joseph cannot hear us.
Yes. Joseph, can you hear me? Okay, then we will contact with Joseph through using the chat.
Yes.
Then I will invite you to take now the lead to. We have, so far we are not having a question and answer received by the audience, but I think that it will be good if you can interact with Joseph, and you can tell us more in deep, or probably more in a different way from the human perspective. What were your personal lesson learned from this pandemic? Because you have explained very well that we have to learn to react in other way. At personal level, what's your lesson taking to home?
So, yeah, thank you, Enrique. And by the way, we also are in contact through WhatsApp through some of our young social media people of the society that have been attending the webinar. So I think they are posting me some questions on WhatsApp, so I can even ask a question on that. But going back to your question to me, for me, the most important thing at personal level was, I admit, I don't think I was prepared on the 20th of February. That was the biggest lesson learned. If I go back on time, thinking that the data was coming out from China from end of January, we were all seeing the data coming out from end of January. I really don't think any of us thought that something like in Wuhan could happen with that violence and that speed in our city. To me, that's the biggest lesson for the future is, if you see something like this, don't underestimate. I think it's very easy to blame associations, societies, countries, but to be honest, some data was out there. The WHO was trying to say something. China was giving us some information. We could have reacted faster. And I think if you see what's happening in other countries around the world, somehow not everyone is acting very fast. I really don't think we can afford for the next pandemic to lose time in preparation. I really think that we should be ready for a second wave of COVID. We don't know if it's going to happen, but there will be other pandemics in the future. Even if we didn't have anything like this before, remember that the 2009 flu season was particularly hard, and that was already putting some strain on our healthcare systems. The key principles to me is, how do we, as a global society, find a way to spot patterns when there is an increase in transmission of viruses or disease in the community, and how can we use an infrastructure to alert systems very fast? We talked a lot about data science and data sharing in the past, but I don't think the system was there really to share this information in real time. If I could make a wish, I really would make a wish, that Europe as an entity really tries to work on this, to try to overcome some issues, of course, that we know we may have with GDPR and so on, but really to try to work on a system where we can have really a wide alert system. I suspect the technology is out there. We just need to get together to be able to put it in place better for the future. And coming from an intensivist point of view, I think for the next virus that will affect, or the next bug that will affect the respiratory system, and very likely, I suspect every time in the human history we will be faced with significant disease, very commonly it will be with a virus that requires respiratory support, advanced respiratory support. I'm sure that this will not be the last one that we will see. In order to do that, we need to increase the competencies for intensive care. With the European Society of Intensive Care Medicine, we represent everyone working in intensive care, doctors, nurses, allied health care professionals. We realized we didn't have enough of these people, and we need to find ways to either bring more competence where they're needed. That's why I have this vision of an healthcare army of ICU people, but at the same time, we have probably to work in a long-term plan, maybe a 5-year plan, a 10-year plan, where we work towards an increase in the competencies for intensive care across Europe. We represent intensive care professionals, and for instance, you may know, we discussed this the other day, that even there is no free movement of intensive care professionals in Europe. We need to work on that. I don't think we will have an excuse in 5 years if we not find a solution for something like this. I think we have the duty to lead this process together.
Thank you very much. Duly noted. I think that's strong messages to the policymakers in Europe. So it's something that should be looked carefully. And I think I have the impression as a functionary of the Commission that everyone is looking in that direction. But of course, it will need some time and some coordination. Your role here is fundamental. The clinician role is fundamental to understand the real situation, what you are doing every day. That sometimes is very well perceived by the other levels of the responsibility.
We're very happy that you're giving us a voice and you're listening to us.
I have a very concrete question coming from the audience. One is quite interesting. I don't know if you will have an answer for that. It's about their representation of if there is any difference based on statistics, on evidence based on different ethnic groups. That's a question coming from Mohamed El Hajek.
So it really depends a lot on different countries. Funny enough, COVID-19 is bringing to surface and to the spotlight a lot of things that we knew from before in severe disease and critical illness. And it's just because the volume of patients that came to our units and to our healthcare system is so high and so big for COVID-19 that we talk as if it was the first time about this patient. Just to give an example, and then I will touch on this as well. There is a lot of talking now about what will happen to this patient after they leave the intensive care unit. How is going to be their pathway to recovery? Because their lungs are being affected. They spend a lot of many days in the intensive care. Actually, in intensive care, we talk about this as post-intensive care syndrome. There's nothing new for us. It's just that the number of pneumonias that came at the same time in 3 months in Europe has never been so high, so we will see a lot of these patients. But the problem was known to us. It's just that the volume of this problem will be bigger. In terms of ethnic data, I'm not aware that there is anything published yet in terms of ethnic data in this sense in Europe. However, the biggest confounder is proper social differences. So it's very clear that if you live in an area that is deprived and doesn't have the same access to healthcare, the same access to the wealth of other areas, usually patients that come from these areas, we know that they will do worse when they have healthcare programs. And this is something, again, that was known even before COVID. There are data coming from the UK, some interesting data, for instance, coming from different boroughs of London and postcodes in London where this is apparent. There is data coming out now from minorities and from different ethnic groups in America. We know that if you basically live in a disadvantaged social situation, this is going to affect you. Indeed, it's a very important topic. People were saying that COVID-19 was a kind of a social equalizer because it was going to everyone. I'm not sure it's true. I still think that the frail part of the population, if they get infected, they have less chances to make a good recovery compared to others. And that's why, even without going into ethnic groups, I think the biggest problem that we have, if you look at the case fatality rate, is look at our poor old population. For something where we don't have a specific vaccine or a specific, we don't have a vaccine or a specific cure now. Again, I think we need to put every single effort to try to stop the virus going to these people, because we know that when they become infected, the chances of recovering are much less than for younger, healthy individuals. So I think, again, this is not just about COVID-19, but COVID-19 has shown much more how important this is. And I think a society like, a wide society like Europe should have at the deep of the heart here the concept of protecting the frail part of the population from becoming infected from diseases like this.
I think that, Fabrizio, thank you very much. We have a question, probably it's addressing Joseph. We have a question coming for Jörg Weimann. He is asking, thank you very much. Did you hear about suicides of COVID-19 patients, or are there even any data on that?
COVID-19 patients, you said?
Yes.
No, well, it didn't reach to me. It is, the problem here is that it is still quite new, and everybody is gathering their data. And of course, many research was directed in the first instance to the treatment of those patients. And usually, once everything is a bit more stable, we are coming back to our patient population, and then we will see when we do an analysis, especially 1 year later, we normally invite our patients back, and we get from them very useful information. Then we will actually have these sort of informations. At this moment, the patients that have been followed so far, and there is also a central registration system, we did not hear any suicides. What we know, maybe that's not the question, but what we know is that the ones who have survived are usually very grateful, because this was something of big caliber, and we every now and then receive through the radio, through the newspaper, or through direct contact to our hospital, thank you very much messages. But no suicide has been reported so far.
Great, thank you very much. That's good news, I would say. No, I have a further question to Maurizio, following the previous question of the ethnic differences, and it's a question from Ernie Okori. It's about if there are any ethnic differences with respect to the recovery rate.
Not that I'm aware of. Again, going back to what we know about intensive care in general, for COVID-19 we still don't have specific data because it's too early, because the majority of long-term data, from Europe will be from the end of February. So the first survivors are only 3 months down the line. However, like Joseph was showing a very important paper, for instance, from Margaret Herridge, we know that the long-term recovery of patients with significant respiratory failure, RDS, and COVID-19 gave basically this type of respiratory failure, gives an important burden to long-standing for the life of these patients. So, and this is what I was saying before, also in terms of the post-intensive care syndrome, is we do know it is a problem. It was a problem even before COVID-19, but now it is being put to the surface because, again, we've seen the number of pneumonias that normally we would see in 12 to 18 months concentrated in 6 weeks to 12 weeks. So there will be a lot of patients that require rehabilitation, a lot of patients that require to try to go back to a normal life. The reason why we do this job, we love this job, is because we want to give an opportunity to people to make a good recovery, to go back to a good quality of life after intensive care. We do it and we put so much effort because we believe that if we give it to the patient that could benefit from this, the recovery starts from the moment that you are in the intensive care. Of course, the baseline condition of patients do matter. So while I don't have data on ethnic groups and recovery, the data on baseline conditions, and for instance, frailty, it's a very important concept now. Frailty is the degree to which you basically, in response to the harm that could come from an infection or to a trauma, to critical illness in general, you can recover. People that are very independent and very fit, usually they recover better. And sometimes even old people, if they are very fit and they go on their bikes, they can still do a good recovery. While in comparison, we could have younger people that maybe have significant comorbidities, they are more frail, they already have some degree of dependency on others. These people may recover worse, or sometimes they may not even recover. So I would say the baseline physiological reserve of patients plays a massive role on how you can react to critical illness.
Thank you very much, Maurizio. We are having two questions more. I'll let you to decide if Joseph or you will come back to this. And it's related with the use of anticoagulants. The question is whether you are having, what's your experience, and if you see an outcome improvement with the use of anticoagulant, or there is any evidence.
I can start, and then Joseph can start. I can tell you the summary of the evidence is, we know that thrombosis is common in this disease. However, we also know from the past that thrombosis is common when you have a disease with inflammation. So this is an infection with inflammation, and the thrombosis is very commonly an end pathway of inflammation. So the big question is, if I anticoagulate you, will I stop before the thrombosis occurs some of the side effects from it? Now, we don't know the straight answer to that. What we do know is that the rate of thrombosis is significant in these patients. Depending on the series, we did a study in my hospital. I didn't show that before, but it's similar rate to the HELM study that I showed before. So, in that study that I was showing in my presentation, up to 16% of a critical ill patient had evidence of a pulmonary embolism. Now, if you have evidence of that, of course, you will treat and you will anticoagulate. What everyone now is trying to find out is, if I start anticoagulation before the problem occurs, can I prevent this? I would say, I don't think there is strong evidence to anticoagulate everyone. There will be a big jump from association to causality there. And also to anticoagulate everyone that comes to the hospital, maybe we will see more side effects from anticoagulation in those patients that maybe don't have a problem like that. What I do in my practice, I have a very low threshold to search for complications, and also I do individualize as much as I can the thromboprophylaxis of my patients. So I will search if there are more risk factors, obesity, some more factors related to long immobility of these patients, where I decide to increase the dose, individualizing. But no, I don't use an anticoagulation approach for everyone. I give thromboprophylaxis to everyone, and then on individual cases I will go on anticoagulation. I don't know if, Joseph, you want to comment on that.
I think on that, I completely agree with you. I would like to bring the attention to a different aspect of the thrombosis. Because if you remember, Maurizio, when we had our first webinar where people were so hungry for knowledge that there were under 32,000 people watching it in the end, there was a professor from China, from Wuhan, and he was saying a couple of things. The one, you have said it already, that the lung is very compliant. That was one of the things. The second thing, he said that, but they were still hypoxemic. But there were no knowledge behind it because it was so new. We saw that as well. The third thing was that he was saying the patients about a week later are having circulation problems suddenly, and they are having, they are in shock, and they are sometimes even dying because of cardiac or circulatory problems. What now we at least know more about it is that this is not only an oxygenation problem, but it's also a circulation problem. These patients, a week later, suddenly circulation failure, they were having it. They were also, most probably, they could have had a heart infarction. They could have a pulmonary massive embolism. That's why they were suddenly dying. And also the hypoxemia that we have, the low oxygenation, that it was probably not only about ventilation, but it was also about dead circulation in the lungs due to thrombosis. So I think, yes, we have to be very carefully apply our thrombotic therapy, prophylactic therapy, and we also have to be careful that the normal parameters that we measure whether the patient is okay with antithrombolysis therapy or not, they may not apply here. So we have to be careful on that. But I also would not do it routinely for everybody due to the complications that we may get.
Thank you very much, Joseph. We are reaching the end of the meeting. Just let me put just one last question. We will come back to other questions. We have several questions here still, but we will come back in written to them. We will record all the questions. That's a question, but probably is the most controversial one now is, what are your comments on the current status of the antiviral therapy? Or recommendation on that, which is not an easy question. That's coming from Jörg Weimann.
I can be very short, then Mauricio can make it a longer answer. we don't need
Again, I think, here there is a lot of personal preferences in this. I think, as I was trying to say in my talk, the anxiety of clinicians to try to find a fast answer for something that's so overwhelming made us try a lot of different drugs, even a lot of antivirals that maybe we would have not tried like that at the beginning. But I really believe what has caught us by surprise was the volume of patients. If we only had 5 or 6 patients, we would have never thought of trying some of these drugs.
Yeah.
So I'm not a big fan of trying things just for trying. However, I am very pleased to see suddenly after a few months that we have some trials coming out. So you may have, I think the person that asked the question may have referred to the remdesivir trial. Now that was a trial on 1,000 patients. It's an interesting trial. There was a change in primary outcome only a few weeks before it was published, even though they didn't know the result, but there was some controversy there. If you see, there was no signal, no significant drop in mortality. There was a faster recovery for these patients. So we start to see something there, but I don't think there is anything that is going to change practice massively. I'm waiting to see some data on convalescent plasma, which is also being interesting. But if you're asking what I start in my unit, I've not started. I had a lot of patients coming with some drugs started before, but I didn't start any adjunctive therapy apart from steroids. Steroids is the only drug that I use on individual cases, and of course what we discussed before about anticoagulation. But I didn't, and if I would get sick, I don't want to have hydroxychloroquine.
And let me say one last thing there, because you have also mentioned during your talk, we are always open to use these drugs in trials. So it's not, we may not use it, but not use it routinely to everybody. But REMAP-CAP that you mentioned is, the center is my department. So we are also using these sort of drugs in the research setting, but not in the treatment setting.
And that's something important. REMAP-CAP, I didn't have the time to comment too much on it, but I think it's a fantastic multinational effort. And this was a platform of adaptive trials exactly to respond to community-acquired pneumonia. Now, COVID-19 is part of the family of community-acquired pneumonia. And actually, I would invite people to try to participate in platforms like this and to be ready either for a second wave or maybe for the next pandemic.
Let me add on this. It's very important that we keep, eye on the clinical trials and links to our clinical practice, because it's really where we can find the solution for many patients. So thank you very much for this evening webinar and all efforts and quality of presentation discussion. So Enrique, I understand we can close now.
Yes, we can. We can close. Thank you very much to all of you. Thank you very much to the participants for the questions. We will come back to your pending questions, and especially, of course, to Mauricio and to Joseph. It was really incredible, your presentation. We really appreciate your time for this. Thank you very much. Have a safe and relaxed evening, and see you soon.
Thank you. Thank you. Bye-bye.
Bye-bye.